Hi everybody, it's Richard again from the University of Birmingham in the UK. In this talk, I'm going to give an introduction to systematic reviews of prognosis research and prediction models. And if you've looked at some of the other videos that I've done, you'll know that I do a lot of work in prediction modelling research. Here I'm looking at how we review the evidence about prediction models and about other aspects of prognosis research findings through systematic reviews and evidence appraisals and meta-analysis and so forth. Okay. Part 1, an introduction to prognosis. So prognosis is one of the most fundamental aspects of healthcare decision making. This was recognised by Galen, 2nd century AD. This quote, "Patient trust was essential in the healing process. It could be won by a meticulous bedside manner, by meticulous explanation, and by a mastery of prognosis, an art demanding experience, observation, and logic." And that's still very much true today. In fact, even more so as we have a big drive towards personalised and precision medicine. So, formally, prognosis is the forecasting, i.e. the prediction of future outcomes based on current information. So, given what we know at our current health state in time, maybe it's a diagnosis of a condition, what's the prognosis of an individual? Or in a population of individuals with a particular condition, what are their likely average outcomes? And because of this drive towards personalised precision medicine, there are literally thousands of prognosis studies published each year, including thousands of prediction models, predictive algorithms. Of course, now many of them are based on AI, machine learning approaches, statistical approaches, which are supposedly predicting individual outcome risks and values for people to use in practice to make decisions. But unfortunately, often the majority of prognosis studies are quite poor quality, very variable in their standards, shall we say, and they often have conflicting findings. So if you think yourself as a doctor, a healthcare professional, somebody who's making policy recommendations, when you have a body of evidence and you need to look across that evidence, you need to think about what's the most reliable bits of that evidence, how do we appraise that evidence, how do we synthesize that evidence to come up with some overall decisions about, for example, which prediction models to use in practice, which factors are prognostic, what's the way that we communicate prognosis information to patients and the population and so forth. So this motivates systematic reviews of prognosis research and prediction models, which is my focus today. How we identify, appraise, and synthesize, meta-analyze the evidence to inform healthcare based on prognosis and prediction models. So part 2, the basics of systematic reviews of prognosis research and prediction models. So first of all, use the Progress framework. So I co-led the Progress framework, which in 2013 published a series of 4 articles in the British Medical Journal and PLOS Medicine. Our aim was to try and improve the quality and impact of prognosis research in the context of a framework identifying 4 related but different aspects of prognosis research, moving from overall prognosis in the population to identifying prognostic factors associated with changes in the prognosis across individuals, to models that make personalized, individualized risk predictions, to predictors of treatment effect. Now, the Cochrane Prognosis Methods Group, who were set up to establish systematic reviews of prognosis research, based their guidance on this Progress framework, in particular focusing on these first 3 areas, and that's going to be my focus for the rest of this talk. So just again, so we're on the same page, what do we mean by overall prognosis? So this is average population level prognosis. Here I'm just displaying the average prognosis of individuals diagnosed with breast cancer over 5 years across different countries. So some countries have overall prognosis close to 80-90%, others have a lower overall prognosis. Progress 2 is prognostic factor research, where we're looking to see what factors are associated with changes in prognosis across individuals. Here we have 3 subgroups of women diagnosed with breast cancer, and the groups are defined by tumour grade, and those with a lower tumour grade have a better survival prognosis than those with a higher tumour grade. So tumour grade is a prognostic factor. And thirdly, prediction model research or prognostic model research. This is where we have multiple prognostic factors, multiple predictors, and we have some sort of algorithm, a regression equation, a random forest, a neural network, some black box maybe that's on some system, maybe a web tool like this one. This is for the Predict breast cancer outcome prediction model, where we input information about an individual such as their age, menopausal status, ER status and so forth, maybe inputting some treatment options, and the model will output for that individual the likely prognosis for individuals similar to the individual that you put in their predictor values for. So for this individual, 93% of individuals with these characteristics are alive at 10 years. So that's a prediction model. Okay, so base your review on the progress framework. Are you looking at overall prognosis? Are you looking at prognostic factors? Are you looking at prediction models? Next thing is to define your P-codes. So P-codes is an extension of the PICO system for systematic reviews of interventions. So we have the population, the index. Here it's the factor or models of interest. For overall prognosis, this wouldn't be relevant. Comparator. This is other factors, maybe adjustment factors, factors you're wanting to account for to then see whether your index factor has added prognostic value over those. Or another model that's out there you want to compare your index model to. Again, for overall prognosis, this is often not relevant, although there may be comparator populations. The outcome, this is the outcome of interest for prediction. The timing, this is a very critical addition for the prognosis review situation, because we have multiple aspects of timing. We have the start point, the moment at which you make your prediction, your prognosis, and you have your horizon, your prediction horizon. Are you forecasting, for example, the probability of survival at 1 year, at 5 years, at 10 years, or is it across all those time periods? So that's very important to specify. And then, of course, the setting. So the healthcare setting, other contextual factors like country. When you're looking for the evidence, you need to search and select what prognosis studies you're going to include in your review. Sadly, current search filters for prognosis studies are quite limited. Primary studies are difficult to identify. They use a variety of different designs and often inconsistent terminology, so it's hard to search for them with any specificity. Basically, this means you need a broad search strategy, and you end up with large numbers of reports, so lots of papers to screen, and ending up with a large number needed to read, just to get one relevant paper. Selection decisions can be difficult based on the title and abstract alone. Again, because the terminology, it's very difficult to see what a study is until you actually open the paper up in full. And indeed, if you open that paper up in full, you may reveal a fuller set of outcomes, prediction horizons, factors and models that have been looked at. So it's important, I think, a lot of the time to actually screen based on the full paper. In terms of data extraction, after you've identified your relevant studies, there is a data extraction checklist, which is called the CHARMS tool, which I would recommend that you use as a basis for data extraction. So for overall prognosis, this is CHARMS OP. For prognostic factors, this is CHARMS PF. And for prediction modelling studies, this is CHARMS PM. So this has information that you should be extracting about, like study design, participant selection criteria, your time points, outcome definitions and measurements, the analysis methods and results. So this is a lot of time needs to be taken for this data extraction. There's a lot of information to extract. In terms of results, what are the sorts of things we're looking to extract? Well, for overall prognosis, we'd be looking to extract measures such as the average value in the population, the average instance in the population, the instance rate in the population for the outcome of interest. Prognostic factor effects, we'd be looking at things like mean differences, risk ratios, odds ratios, hazard ratios. And for prediction model performance, we'd be looking at things like discrimination, calibration, and clinical utility. So clearly, depending on the type of prognosis review, the effect size, the effect measures, the statistical measures of interest will vary. Now, this can be a very challenging process, especially for prognostic factor and prediction model studies. The information is not always easily attainable. You may need to use indirect estimation, so take other information that is reported to indirectly estimate the statistical measures that you're interested in, such as calibration performance of a model. Standard errors and confidence intervals may be missing for the estimates. So this is a careful process that takes a lot of time. Also, just things like estimates and standard errors need to be made sure they're on the correct scale for subsequent meta-analysis. So yeah, this is a challenging, time-consuming part of a review. Once data has been extracted, we would look to do a risk of bias and applicability assessment of the studies. And so there are various tools that are either forthcoming or are out there. So Probust AI is the prediction modeling risk of bias and applicability tool that's out there. That's published in the BMJ. Forthcoming are risk of bias tools for overall prognosis and prognostic factors. So look out for those shortly. All of these tools have signaling questions within particular domains, and those domains are mainly participants, outcomes, and data analysis. So a series of questions, people who are doing the appraisal will need to go through those questions and answer them and make then overall decisions about whether a study is at low risk of bias, high risk of bias, or unclear. This is something that does require specialist knowledge because you are examining the quality of prognosis studies. So you have to understand prognosis studies in detail. For example, if you're appraising a prediction model development and evaluation process, that's quite an intricate thing. So you need to understand good practice in that area. So not to be undertaken lightly. Meta-analysis. Now, meta-analysis in this area is often not sensible, and that's one of the key things for me to say. You don't have to do a meta-analysis. Many studies will have heterogeneity so the set of studies that you identify will often be heterogeneous. For example, in the prediction horizon, cut points used to dichotomize continuous variables and outcomes, different measures of measurement, different effect types. It just may not be sensible to pull the evidence because you've got to think, what does that average result mean if everyone's using different cut points and methods of measurement? If people do decide it's meta-analysis is worth doing, then a random effects meta-analysis is usually required. Even when you think about doing a meta-analysis of similar studies, so studies with similar cut points and prediction horizons, there will often still be heterogeneity that can't be explained. So don't just report the pooled effect and 95% confidence. We'll also report the estimate of between study variance and a 95% prediction interval for the potential effect in a new study. Method regression may be required to examine between study heterogeneity, so what are the factors likely causing that? Publication bias is a common threat in prognosis studies where the prognosis studies with the more significant, shall we say, findings are more likely to be reported. This may lead to small study effects, but also heterogeneity may lead to small study effects as well. So just bear that in mind, that small study effects does not necessarily equal publication bias. Usually we would do sort of standard inverse variance weighted meta-analysis methods, but in some situations with rare events, a one-stage method may be required, and a multivariate meta-analysis may also be needed, for example, to account for correlations between different multiple outcomes or between multiple effect measures of like discrimination and calibration, which is easier if you have the raw data. A few examples, just very, very quickly. Here's an example. What is the incidence of fatigue after stroke? So here's a review that was done, and we've got the incidence estimates, so the fatigue proportion in the population after stroke, the time at which this fatigue was measured, which is clearly quite heterogeneous, but the authors still put this together. And so we have an average proportion is 50% of people have fatigue after stroke, but there's a lot of heterogeneity depending on the country, the time, and so forth. And we have a very wide prediction interval that goes from 0.24 to 0.76. An example in prognostic factors, so the review was done to examine whether recovery expectations, which was a dichotomized measure, is a prognostic factor for work participation at about 12 months following low back pain. The review examined the unadjusted prognostic effect in terms of an odds ratio, and it also looked at the adjusted effect. And we can see that the unadjusted effect is very clearly suggesting that it's prognostic. The adjusted effect is not quite as strong, but still showing there's some added prognostic value here. Lots of heterogeneity still, and the prediction interval is very wide, but the majority of the interval suggests that there's likely that this factor is prognostic in most settings. And then lastly, a prediction model example. This review examined the predicted performance of the Euroscore 2 model for estimating risk of in-hospital mortality in patients undergoing any cardiac surgery. And they looked at various measures. They did a meta-analysis of the O over E, the observed over the expected, and that was quite close to 1. Again, lots of heterogeneity though, with some studies over-predicting and others under-predicting. So a wide prediction interval suggesting that local recalibration may be necessary and important. They also looked at the C-statistic and measured discrimination, and again, lots of heterogeneity, and the average C-statistic 0.79, but a prediction interval suggesting it could be quite different than that in any one local setting. So, yeah, another example. After the meta-analysis and bringing it all together, we need to do a summary of findings. So summary of findings tables appear at the end of a review. They need to be tailored to the review-specific PCOTS question. Each row should correspond to one outcome and one particular index factor or model as relevant. Many people will know about the grade guidance. This has not really been developed in full for prognosis and prediction model research at the moment. Some papers on overall prognosis and unadjusted prognostic effects, but further development is required for adjusted prognostic effects and in particular prediction model performance. Reporting a review is important. We need to be very transparent in our reporting in all our aspects of medical research. So for prognosis reviews, we need to use adaptations of the tripod guideline. So this is tripod SR, OP and PF for overall prognosis and prognostic factor reviews. This is in progress, should be forthcoming soon. And for prediction model studies, tripod SRMA, which we've now relabeled tripod SRPM, is already available in the BMJ. So check out that for reporting reviews of prediction model studies. Lastly, I want to introduce something very exciting, a new Cochrane Handbook. So the Cochrane Handbook for Systematic Reviews of Prognosis Research and Prediction Models is to be released at the end of 2026 in hardback form, but the exciting thing is that actually some chapters are already out there and emerging gradually online. And check out this QR code which will take you to the website where the chapters are available in draft form, so any feedback would be very welcome. We're going to be checking the proofs soon and working towards that hardback copy, but the book will be a living document and we'll be updating it regularly. There are 17 chapters in this book taking you through the whole process of doing a review of prognosis research and prediction models, written by experts in the field, mainly driven by members of the Cochrane Prognosis Methods Group, and you can see the editorial team at the top there. So this is the first handbook dedicated to reviews of prognosis and prediction models, covering the 3 types that I mentioned: overall prognosis, prognostic factors and prediction models. Also, for those sort of new to the field, we don't just jump in at the review process. There are a number of chapters that give a foundation to the topic. So we talk about the relevance of prognosis research and prediction models. We outline the progress framework, and we talk about primary studies too in terms of their design, analysis, statistical measures and so forth, to give people a grounding before then going on to the step-by-step guide essentially for doing a prognosis review. You know, talking from defining the research question, the PCOTS, to doing the data extraction, searching, selection, risk of bias, meta-analysis, summary of findings, and reporting and so forth. Yeah, so we're really excited about that, and I'm really pleased to be sharing that with you today. Okay, so I've left the QR code on there on the right hand side, but here's some other references that you may be interested in checking out if you want more details. In the next year, I'll be adding more videos and specific tailored guidance for each of the different types of reviews. We're also introducing a new course at Birmingham. Look out for that being advertised for next year, 2027. And we already do existing courses, which you may know about, in prognosis research and risk prediction modelling and meta-analysis. Anyway, I'll leave it there. Thanks so much for listening to this talk, and speak to you again soon.